meeting is now being recorded.
Thank you, Sue, and good afternoon, everybody. I'm delighted to be here again today. I'm talking about COPD rather than asthma. There are two webinars in this particular topic. Today will be a COPD overview, and then tomorrow we'll be really focusing more heavily on the various COPD medications and treatment options. So for today, we're going to talk about COPD education and management. Just as with asthma, the goal of all patient education is to help the patients take the actions needed to control their asthma or COPD, or in some cases there's actually an overlap syndrome. So becoming COPD prepared, there is one way to do this, or one approach is called the 4-step approach, and I'll share that with you. So it's a framework for COPD care, and it follows the acronym of STEP. So S means screening patients at risk, T means testing and diagnosing by the use of spirometry, E is then educating your patients about COPD, and P is provide care and support. So screening for COPD is possible using a validated screening tool, and it's a very important step in identifying patients who may be at risk for COPD, as you'll see in just a minute. Just as with asthma, and you'll hear me say this over and over again, many things are similar between asthma and COPD. Just as with asthma, COPD is often underdiagnosed and undermanaged. And it's really unfortunate because of the top 5 causes of death in the United States. COPD is the 3rd leading cause of death after heart disease and cancer. And one of the reasons for that is because COPD is identified at such late stages. So there is a tremendous concern about the underdiagnosis of COPD in the United States. We believe, and statistics tell us, that there are approximately 24 million adults who have evidence of impaired lung function that would be consistent with or indicative of COPD. Of those 24 million, only about half of them have actually been diagnosed with COPD. So half of the adults with COPD are actually going around undiagnosed. And most of the patients with undiagnosed COPD are younger. They're under 65 years of age. COPD is thought to be a disease of the elderly when, in fact, it is more and more on the rise in younger patients, and it's often missed in that age group. So why is there such a significant burden of COPD, and why are approximately half the people with COPD undiagnosed? Well, patients typically seek medical attention by the time they hit the moderate stage of COPD. When they have an earlier stage, a less severe stage, mild stage, they are attributing perhaps a dyspnea to being out of shape or just the normal course of aging. And it's not until the dyspnea gets more severe, so they actually present to have the diagnosis made by the time they have moderate to very severe COPD. And that's when it's oftentimes confirmed on spirometry. So 81% of the patients already had moderate to very severe COPD at diagnosis. So you have missed those many years leading up to that fact when there could have been interventions that have been taken, when they could have worked more heavily, perhaps in smoking cessation or whatever those interventions were, that could have preserved lung function and prevented the diagnosis at that very late stage. Every year, due to COPD, there are approximately 16 million office visits and 672,000 hospitalizations. More than 22% of Medicare patients hospitalized for COPD were readmitted within 30 days of discharge. And a third of those readmissions were due to COPD. So it does extract a very heavy burden, both economically and also on the patients themselves. So why is it important to diagnose earlier rather than later? Because the lung damage starts early and it's progressive. Unlike asthma, where you can have certainly some impact on lung function, that is usually reversible. With COPD, it is no longer reversible. The breathlessness occurs early, and it increases with severity, and is often underestimated. Like I said, how many times have you had a patient say, well, yeah, I'm more out of breath than I used to be, but I put on a couple pounds over the years. It's just what happens when you get older. Well, not necessarily. It could be, if they have risk factors, it could be COPD. Inactivity is common, but we really have to assess that by a healthcare provider to make sure that it is just maybe inactivity or maybe more weight and not indeed a lung condition such as COPD. Because patients, even who have mild disease, can have exacerbations, and every COPD exacerbation has a significant impact on lung function and actually takes that lung function down a notch, and they never recover back to baseline. So the earlier we intervene, especially with smoking cessation, it leaves the patients with more lung function. It preserves that lung function, which is just critical. So definition of COPD. COPD is defined by the American Thoracic Society, the European Respiratory Society guidelines, as preventable and treatable disease state that is characterized by airflow limitation that is not fully reversible, unlike asthma. The airflow limitation is usually progressive, and it's associated with an abnormal inflammatory response of the lungs to noxious particles or gases, primarily caused by cigarette smoking. Although it affects the lungs, it also produces significant systemic consequences. So according to the GOLD guidelines, and GOLD are the Global Pulmonary Obstructive Lung Disease Guidelines, GOLD guidelines, COPD is characterized by chronic inflammation throughout the airways. So COPD really encompasses two different entities, chronic bronchitis and emphysema. Those are both under the COPD umbrella. So chronic bronchitis is clinically defined as a chronic productive cough for 3 months in each of 2 successive years in a patient who might have other causes of, if there were other causes of productive cough that were excluded. So there really is no other reason other than this chronic productive cough, and they're at risk for COPD. Emphysema is defined as abnormal, permanent enlargement of the air spaces distal to the terminal bronchioles, which is accompanied by the destruction of their walls, yet without obvious fibrosis. Whereas emphysema is actually destruction of the alveolar sacs. Again, unlike asthma, where that lung function can be reversible and there's not permanent damage, typically not permanent damage in the air sacs, with emphysema, you will see the destruction of the alveoli. And with chronic bronchitis, you will see a chronic productive cough. So it is really a multi-component disease. Like asthma, you can certainly see bronchoconstriction. You have those bronchial smooth muscles around the airways, and those muscles tighten, and they surround the airways and make it more difficult to breathe. There's also underlying inflammation, just as with asthma. So there are some structural changes that also narrows the airways, increase in inflammatory cells, again, very much like asthma. The differences are on the right side, structural changes. You don't typically see the permanent damage to the airways and the alveoli with asthma as you do with COPD. And you also don't typically see the mucociliary dysfunction, those cilia that are beating back and forth and help with airway clearance with mucus. Those cilia are often damaged especially with smoking and exposure to noxious chemicals, and so the mucus is not able to be cleared in a productive and efficient manner. So some diagnostic indicators for COPD, obviously dyspnea is very common. It happens usually just with exercise, so that's why it can also fool somebody because, you know, we can all get out of breath with exercise, and some people, again, may attribute it to weight or being out of shape, so they don't think much about it because they may just be short of breath with exertion. But eventually that will progress to occur with less exercise and less exercise, and eventually they'll become dyspneic even at rest. Then there can also be a chronic cough, and that can be fairly intermittent when it's early in the disease process. It usually is in the morning, but then as, again, the disease progresses, that's why it's important to really diagnose early and prevent this progression. That cough persists throughout the day with the disease. A sputum. There can be really any kind of pattern of chronic sputum production, which could indicate COPD, again, unlike asthma. And then we also look for risk factors, exposure risk factors, certainly history of tobacco smoke, but also occupational dust and chemicals, because there are also occupational causes of COPD, and even things like smoke from wood-burning stoves and heating fuels can also contribute as a risk factor. So who is a COPD patient? I think we're all very familiar with these old Metter drawings that I learned in nursing school many, many years ago. The one on the left was the pink puffer, and the one on the right was the blue bloater. I hated those terms, but that was what people saw as a patient with COPD, a classic patient with COPD. That myth was COPD is a disease of the elderly. The second myth was COPD is a disease of men. And that's the kind of visual you would be given to look for patients who might be at risk or have COPD. When in reality, our patients with COPD look like these two. They are younger patients, they are women. Those numbers in both of those populations are on the rise. So in reality, COPD afflicts the working age population, and COPD is also, most definitely, unfortunately, a disease of women. So it's not a man's disease. A hypothetical male patient with COPD symptoms, so if a man presented himself to a physician and had typical hypothetical symptoms, COPD symptoms, was diagnosed correctly by 65% of the physicians that this man would present himself to. A woman, on the other hand, same symptoms, same risk factors, was only diagnosed half the time by physicians because they didn't think COPD because she was a woman. So COPD symptoms in women were most commonly misdiagnosed as asthma. So if you have a woman who has traditional classic COPD symptoms, again, the best way to discern whether it's asthma or COPD is with spirometry, but let's make sure we're making the right diagnosis and not calling it asthma or not just missing it completely. There is a screening tool, which I'll show you on the next slide. I'll blow it up a little bit. But this is a COPD population screener. The COPD Alliance recommends the utilization of this simple validated questionnaire. You can download it at copd.org, and persons at risk should be asked to complete the screener. And the screener can help identify people who are over 35 who might be at risk for COPD. So this is what it looks like, and the questions include things like, during the past 4 weeks, how much of the time did you feel short of breath? Do you cough up any stuff, such as mucus or phlegm? Please select the answer that best describes you in the past 12 months. I do less than I used to because of my breathing problems. Have you smoked at least 100 cigarettes in your entire life, and how old are you? And those are risk factors that this tool takes into account and tries to identify whether the person answering this may or may not be at risk for COPD. So this is a validated screening tool that uses those 5 questions to determine a patient's risk for COPD and potentially, if they have any respiratory symptoms, the need for spirometry testing. It's available in English and Spanish, and there's also a treatment room poster. Now, next, with diagnosing, spirometry is the test that measures the amount of air a person can breathe out and the amount of time it takes to do so. So it measures not only lung volume, but the speed at which we can get air out of our airways. It can be administered by trained office staff in a primary care setting, and it is the gold standard for diagnosing COPD, just as it is for asthma. So diagnosis, as I said, often, unfortunately, does not occur until the disease has progressed significantly. So there may be a lack of serious symptoms, there may be poor recognition of these clinical symptoms in the early phase, but even then, COPD can oftentimes be confirmed by performing a lung function test with post-bronchodilator spirometry. That's why it's important to screen these individuals early. If they have any of these respiratory symptoms, screen them early because you could be catching them at a very early stage and help them preserve their lung function. So these are the recommendations from the National Lung Health Education Program. Primary care clinicians should perform an office spirometry test for the following patients. Patients who are 45 years and older who report smoking, either current smokers or those who have recently quit, in order to detect COPD. Or patients with respiratory symptoms, such as chronic cough, sputum production, wheezing, or dyspnea on exertion. Those are classic risk factors that we're looking for. So people, and we're not talking 65, 70-year-olds, we're talking 45-year-olds or even younger, if they have those respiratory symptoms, but especially if they have any history of smoking or living with people who have smoked, and if they have those respiratory symptoms that would be unlike asthma, like the sputum production and the chronic cough. These are things that we're looking for to help just differentiate it from asthma. And actually, if you do spirometry, that should help with that. So spirometry is essential for diagnosing COPD. It's the gold standard. So if someone has these chronic symptoms, cough, sputum, shortness of breath, and they've been exposed to risk factors like tobacco or occupational irritants or pollution, then spirometry will help confirm that COPD diagnosis. And we're looking for that ratio of the FEV1 over FVC. So FEV1, if you recall, is the forced expiratory volume in 1 second. You take in that big deep breath, you put the cone in your mouth, and you blow, 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 blow. You measure all the air that comes out, and most of that air should come out in the first second. That's the FEV1. The FEC is the forced vital capacity. So all that air that you breathed in and then blew out is measured as the forced vital capacity. So the percentage of all the air that you blew out, what came out in that first second, is what we're looking for. If that's less than 70%, that is classically COPD. And we look at that FEV1 number in particular to help determine the stage of severity of the COPD. So COPD, once the diagnosis is suspected, is based on symptoms and a history of exposure to risk factors, and then confirmed by the presence of airflow limitations by spirometry. So there are certainly barriers to spirometry use, and overcoming these barriers will lead to an increase in COPD diagnosis, especially in earlier stages, so we're not catching people at moderate to late stages when the damage has already been done. There's uncertainty about the impact of the test on the outcome, or lack of training on the use of it, or interpreting the results, or time constraints or reimbursement concerns. Those can all be addressed, and if they are, and someone that practices using spirometry on a regular basis, they will definitely see the benefit of diagnosing people earlier and, again, preserving lung function. So the value is clinically, it confirms the diagnosis and assesses the severity. It helps differentiate asthma from COPD, and it helps to assess the response to bronchodilator therapy. It's really relatively inexpensive. They run about $2,000. They're easy to maintain, but they're also well reimbursed. So when you've done a series of spirometries, you will oftentimes recoup that investment, and then you have it in your office, and you're able to do that into the future. And it is a very, very valuable diagnostic and management tool, very valuable. Primary care clinicians can be trained to perform accurate interpretations. Sometimes people who are not familiar with the newer spirometers picture the one on the left, which are huge machines, very cumbersome, very complicated. The new portable office spirometers are handheld, very easy to use, very simple to use, and literally take minutes to actually accomplish in the office. When I worked at an allergy office, I would do spirometries daily with patients, and whether the nurses were doing it, I was doing it, I would just punch in their name, it would pull up their information. We'd do 3 trials. The longest wait was waiting 20 minutes before and after the bronchodilator, but you can move on to do other things in that wait time. But literally, to do the maneuvers takes maybe, I timed it once, I think it was maybe 2 minutes. It's very, very quick. So we're looking at predicted values, and we certainly wouldn't think that someone like Shaquille O'Neal has the same FEV1 as a woman who's 5 foot tall. So it's easy to understand that the FEV1 of a very tall person is larger than the FEV1 of a very short person. And total arm span is a proxy for height. So this measurement could be a substitute for height in patients who have perhaps back disorders and that sort of thing, who cannot stand. So we're looking at normal values that can be affected by age, by height, by sex, and ethnic origin. And all of these factors are put into and built into the spirometer so they can account for these factors and normalize those numbers. COPD then is confirmed by a post-bronchodilator FEV1 over FVC ratio, so forced expiratory volume in 1 second over a forced vital capacity of less than 70%. And then we would give them a bronchodilator and measure, again, the same maneuvers, 10, 15, sometimes 20 minutes before and then again after, short-acting bronchodilator, and see if there's any responsiveness to the bronchodilator. And again, remembering from the asthma webinars, this is what a flow volume loop looks like. The loop on the top is the expiratory flow, and on the bottom, inspiratory flow. So you're taking a big breath, and you blow, 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 and then breathe in. And what we're looking for here, again, is how quickly the majority of that air comes out, which is the FEV1, the first second. So now we're going to move into how do we treat COPD. Once that diagnosis is made, hopefully earlier rather than later, all patients who are symptomatic merit a trial of drug treatment. So maybe there wasn't an impressive change post-bronchodilator, but there was some impact on their lung function, and they still were symptomatic and still at risk for COPD. We could, even if there's not significant improvement post-bronchodilator, we can certainly do a trial of medications. The current long-acting medications can reduce symptoms, can increase exercise capacity, can reduce the number and severity of exacerbations, and can improve their overall health status. The other thing that we can work on, certainly, is smoking cessation. So I use this graph to educate my patients with COPD who continue to smoke. And I explain it the way I would explain it in an office. When you look at the x-axis here and you mark off the age at about 25 years, and then you look at where they are in their age in life here. So actually, if you see this at age 25, all of us have some beginning change or decline in lung function at the age of 25. It starts dropping off very gradually, very normal. And if you've never smoked, you get this really nice wide orange line here. You have a very gradual decline in lung function over life, which is normal. If you are a smoker and you continue to smoke throughout your life, you can see a much, much more dramatic drop-off in lung function. If you stop smoking, say, at 45 years, you can see a more gradual decline. Even if you smoke for years and you stop at 65, you still preserve lung function. You may still be at the disabled stage here, but you can sometimes prevent a premature death. If you stop smoking, even at 65, you're still preserving some of that lung function. Those that continue to smoke are going to see a much, much more dramatic decline. So it's essential that you take the time to educate your patients about COPD, including what symptoms to look for, how to diagnose, and then we'll talk in a minute about what triggers an exacerbation and how to live better with the disease. This is the E portion. Educate your patients about COPD. So that you can find these tools on COPD.org. There's a flip chart developed by the American Academy of Nurse Practitioners, a breath of fresh air that enables clinicians to have a dialogue with their patients, and also videos to show how to properly use inhalers. And finally, P is providing care and support to COPD patients. And that's what all of us as clinicians strive to do at the highest levels, and it's also the fourth step in becoming COPD prepared. So what is your role as care managers working with members or patients who have COPD? Well, you can assist in identifying those patients who are complaining of coughing or shortness of breath and might be at risk for respiratory disorders, and not chalk it up to just aging or maybe a little extra weight or just getting out of shape. So if you have patients who are over 40 years who are current or ex-smokers especially, ask them these questions because they may not necessarily volunteer this information. Do you cough regularly? Do you cough up phlegm? Do simple chores make you short of breath? Do you wheeze when you exert yourself or at night? Do you get frequent colds that last longer than those of other people? So you get a cold, maybe your spouse gets a cold and they shake it off in a week or so, and you get that same cold and it makes a beeline to your chest, and then you have symptoms for weeks afterwards. If your patient answers yes to any of these questions, at the very least, let's consider doing some spirometry testing and see if they may be at risk either for asthma or COPD, especially if they cough up phlegm and they have a regular cough and there's a history of smoking. I would definitely think more in terms of COPD. So promote education on COPD and self-management techniques. Counsel patients on the correct way to use inhalers. I always say if there's a wrong way to take an inhaler, someone has figured it out. I've seen inhalers used every way imaginable with caps on, upside down, sprayed to the back of the head. I mean, you name it. Care managers should be able to demonstrate the use of all newly prescribed devices and then observe the patient's use of each device and do that on every visit because those skills deteriorate so very quickly they will forget oftentimes when they walk out the door. And then question them about their medication adherence in a non-judgmental way, and then take steps to resolve any reported problems. We talked about this a little bit during the asthma medication webinar, but you know, I would ask patients, how often do you think you forget to take your medicines? Because if you just say how often you take them, they're going to tell you every day. And then you say, that's great, but how often do you think you forget to take them? You know, in a typical week, how many days do you think you forget to take them? And then you'll start getting some truer answers. Well, maybe out of 7 days I forgot to take my medicine 5 out of 7. And then you can have another entirely different conversation than, well, maybe the medicine's not working, to, well, how can we get you to remember to take your medicines, or do you have concerns about the medicines that are keeping you from taking it on a more regular basis? So it really is a whole different non-judgmental way of looking at adherence. Care managers can also assist patients in the prevention and management of COPD and exacerbations by identifying and referring patients who might have COPD, educating them on the disease process itself and self-management, certainly counseling them on smoking cessation, recommending vaccinations, and then telling them what to watch for signs and symptoms of a COPD exacerbation. We'll talk about that in just a minute. So you really are well positioned to play a key role in many, many aspects of COPD management. So COPD exacerbation is defined as an acute change in a patient's baseline dyspnea, cough, or sputum. So remember, these are COPD patients who could very well have daily dyspnea, daily cough, daily sputum production. How do we know when it's a true exacerbation? If there is a change from their baseline dyspnea, cough, and or sputum production. beyond their day-to-day variability. So it's not their typical cough, not their typical dyspnea, not their typical sputum. It is different, and it's sufficient enough to warrant a change in therapy. So if we can jump on these, just like with asthma, if we can jump on these exacerbations early and aggressively, we can oftentimes prevent them from worsening, and this is a recognized goal in COPD disease state management. Because again, every time someone with COPD has an exacerbation, it knocks down their lung function to a level where they never regain it, and they will never get back to baseline again. So every exacerbation taking down a notch on their lung function again and again and again and again. So frequency of these exacerbations contributes to that decline in lung function overall and significant worsening in quality of life. So changes in the following, this is what we're looking for again, beyond normal day-to-day variations. Could be acute in onset, and they usually warrant a change in medication. So a change from their baseline dyspnea, from their baseline cough, to their baseline sputum. Increased breathlessness that might also be accompanied by wheezing and chest tightness, increased cough and sputum, a change in the color and or tenacity of the sputum, and certainly fever. You might also see tachycardia and tachypnea, malaise, insomnia, sleepiness, fatigue, depression, or confusion. These can also accompany COPD exacerbations. Also, if there's any decrease in their typical exercise tolerance, fever, and or new radiologic anomalies, that's also suggestive of pulmonary disease, and those could also be signs of COPD exacerbations. So again, defined as acute change from their baseline. There is evidence that supports that exacerbations are acute inflammatory events that are superimposed on the chronic inflammation in someone who has COPD, so they all have some underlying inflammation, but an acute exacerbation are acute inflammatory events. In a 12-month study, 77% of patients who had COPD had at least one exacerbation. 3/4 of the patients who have COPD in this study had at least one exacerbation in the past year. And again, the frequency of the exacerbations contributes to declining lung function and worsening quality of life. So the more we can prevent these exacerbations, the better off we're going to preserve lung function and improve quality of life, because most of the patients with COPD are having exacerbations. So help them recognize and treat them, and tell them to watch for any changes in symptoms from baseline. That's really important to mention to them. Again, from their baseline, is there a change in their shortness of breath, even at rest? Is there more wheezing or coughing or mucus? Does the mucus look different to them? Is there more chest tightness? Are they more irritable or fatigued or have no energy? Is there fever, color changes, rapid breathing, rapid heart rate? These are all things that they can recognize fairly easily on their own. So ways to avoid exacerbations: to wash their hands often, avoid contact people who are ill. They need to get flu shots every year and make sure their pneumonia immunizations are up to date. And then if they have medications, to use their long-term control medications daily. And then quickly get on antibiotics for infections or sinus problems. And then guess what? Just like with asthma, there's a COPD action plan. So it looks like this. It is obviously COPD specific. It looks very much like an asthma action plan. It actually follows the traffic signal theory. You have a green zone, yellow zone, red zone. The difference here, though, is the green zone is when they're doing well. They take their daily maintenance medicines. The bigger difference here is that it includes the signs and symptoms of an exacerbation, and then it allows them to use a quick relief inhaler more frequently, as with asthma. But also in the COPD action plan, you may have options here for adding antibiotics and or oral steroids fairly quickly in the process to prevent that from worsening. And again, red zone is a medical emergency. So I don't know how many of you have ever seen a COPD action plan. They do exist. They can be very helpful, very beneficial, and they should really be a critical part of COPD education. The COPD action plan will tell them when to call the doctor. If they are having shortness of breath or wheezing that does not resolve after using a quick relief inhaler, if there's a change in the color, the smell, the amount, the thickness of the mucus they cough up, if there's new or increased ankle swelling, if they are awakening with shortness of breath more than once a night, they're very tired, that lasts for more than a day, or they have a fever that lasts. These are things that they can be educated about as to when to call the doctor, so we can jump on those exacerbations quickly. And then they also obviously need to know when to go to the hospital. If there's any confusion or slurring of speech or sleepiness during a serious lung infection, if they lose alertness or two or more of the following: So an increased seriousness of symptoms, struggling to use your upper chest, again, a more rapid heartbeat, more rapid respiratory rate, or any severe symptoms, they really should go to the hospital to be evaluated. And there's also a COPD assessment test. This is for somebody who has COPD. Just as there is the asthma control test, this tells us how well their COPD has been managed. And it is very similar. It's a Likert scale, and they complete these questions about coughing and other symptoms they have, and they get a total score. So the questions are, they go all the way from I never cough to I cough all the time. I have no phlegm to my chest is completely full of phlegm. My chest does not feel tight at all to my chest feels very tight. When I walk up a hill or one flight of stairs, I'm not breathless to I am very breathless. I am confident leaving my home despite my lung condition to I am not confident leaving my home. I sleep soundly to I do not sleep soundly because of my lung condition, and I have lots of energy to I have no energy at all. So the range of CAT scores is 0 to 40. A higher score denotes a more severe impact of COPD on a patient's life. So the difference between stable and an exacerbation patients was 5 units. So it doesn't take a lot to throw them into an exacerbation and have a significant impact on quality of life. So again, the role of a care manager in COPD is also smoking cessation. It's the single most effective and cost-effective intervention to reduce the risk of developing COPD and certainly to slow its progression. So smoking cessation has the greatest capacity to influence the natural history of COPD. If you recall that graph that I showed you, even if they don't stop at 45, they stop at 50 or 55 or 60, you're still going to preserve more lung function than if they stop later in life or they never stop at all. So never underestimate the impact that you as healthcare professionals have on your patients by strongly supporting them in their efforts to quit smoking. Lung function begins to improve in 2 weeks to 3 months after quitting. Coughing and shortness of breath decreases in 1 to 9 months after quitting. So there are tremendous benefits to smoking cessation. Again, it's never, never, never too late to quit smoking, and it will always benefit lung function. So again, the orange are sustained quitters, and this is their FEV1. This is lung function versus year, and you can see lung function declines much more gradually if they quit and stayed quit. And intermittent smokers had a more steep decline, but not nearly as severe as those who continued to smoke. They had the most dramatic drop-off in lung function, significantly greater decline in lung function than those who quit off and those who quit for good. So the best strategies to help patients who are willing to quit, and again, we have to assess their readiness to quit, but if they're willing to quit, is to systematically identify all tobacco users at every visit, even if they had quit before. It's always important to ask them again because sometimes or oftentimes they might have restarted, and then to urge them to quit smoking. Again, don't underestimate your impact as a healthcare professional, telling them or suggesting that to them. Determine what their willingness is to make an attempt to quit, and then aid them in quitting and scheduling follow-up visits. So really understand what those roles are and what you can do to help them in those strategies to quit. Sustained quitters had the lowest mortality. Probably not something that would surprise you, but you can see here deaths per 1,000 person years, and of course the sustained quitters had the lowest mortality trend versus intermittent quitters and continuing smokers. And it's not just once and done. Smoking cessation often requires multiple attempts. I always tell patients, never quit quitting. The more often you quit, the more likely you are to quit for good. On average, it takes 10 attempts to quit for good. So they get discouraged, they beat themselves up when they start smoking again, but just tell them that's normal. And the more often they quit, the better chance they're going to have to quit for good. And then we know there are highly effective pharmacotherapy for smoking cessation. There is the nicotine replacement, whether it be gum or patch or lozenges, nasal sprays. And then there's bupropion, which is Zyban, and then varenicline, which is Chantix. So there are multiple therapies available, and they all help improve quit rates for smoking cessation. Some can be used in combination, and some are used independently. There's a wonderful resource I would like to tell you about, and it is the American College of Chest Physicians Tobacco Dependence Treatment Toolkit. It's a complete online resource for you and your patients, You can visit the website down there. Now, you will have to sign in for this to get access to this toolkit, but it is free. And you can download any of these documents and tools, and it's just a wonderful, there are a pharmacotherapy grid, there's patient questionnaires, there's clinical practice guidelines, cessation approaches, treatment approaches, referral sources. It's a wonderful wealth of information. It's free to use, but you will have to register and sign in. But I do encourage you to visit that if you work with patients and you are interested in helping them through that cessation journey. Also, there are COPD education topics, such as pulmonary rehab, maintaining proper nutritional status, conserving energy and controlling stress, controlling breathing, pursed lip breathing, oxygen therapy. There are support groups. In the Grand Rapids area, we have a Better Breathers Club. In your respective communities, you may have other types of support groups for people with chronic respiratory conditions. So you may want to sort those out and have those available as resources to patients, especially when they're newly diagnosed, because they really are grasping at that time. It is a complex chronic disease, just like asthma would be, or diabetes, or anything else, and they are going to need support. They are going to need help. It is distressing to get a diagnosis like that. They probably already have some symptoms, and they are scared. They feel alone. So if you can help them with these different topics, and pulmonary rehab is a wonderful resource for patients who would qualify and benefit from that, but there are a lot of other opportunities for them that are available to them. So if you have a list at the ready, even smoking cessation resources in your community, it would be really helpful to be able to go over those resources with them. We're going to move in now to diagnosing and staging the severity of COPD, and this all comes from the Global Initiative for Chronic Obstructive Lung Disease, or GOLD, or the GOLD guidelines. Just as there are national clinical practice guidelines for asthma, these are global clinical practice guidelines for COPD. These are worldwide COPD guidelines, and they are typically updated every year or every other year. So again, the GOLD guidelines is the gold standard for COPD diagnosis, management, and treatment in the world. So they define COPD, again, as a common, preventable, and treatable disease characterized by persistent airflow limitation, progressive, associated with enhanced chronic inflammatory response in the airways and the lung to noxious particles or gases. And exacerbations and comorbidities contribute to the overall severity in individual patients. So just their reviewing of risk factors. There are also genes. So there's a genetic form of COPD. It's called alpha-1 antitrypsin. It's a deficiency. And if you have patients who have never smoked, but they have those chronic respiratory symptoms, especially if they have other family members with the similar type symptoms, it may be worthwhile to test them for alpha-1 antitrypsin. It's not common, as common certainly as a cause as smoking could be, but it's not uncommon either. So it's worthwhile checking for that, especially if there are other family members with similar symptoms. So there is a genetic component in some patients, but oftentimes it's exposure to particles like tobacco smoke, as I said, exposure to occupational dust, organic, inorganic compounds, indoor air pollution from heating and cooking with biomass, poorly ventilated dwellings. Outdoor air pollution can contribute to COPD as well. Lung growth and development, gender, age, respiratory infections, socioeconomic status, history of asthma, chronic bronchitis. These are all risk factors for COPD. So you have, again, risk factors such as cigarette smoke, occupational dust and chemicals, environmental tobacco smoke, so exposure to people who are smoking, and indoor and outdoor air pollution. There's also the genetic component in some people. There's also infections, which are risk factors, and socioeconomic status. There is, as with asthma, there tends to be a burden on individuals from lower income groups, and they bear a disproportionate burden of not only COPD, they also tend to smoke more, and they also are often diagnosed at later stages. We're looking overall at aging populations, even though COPD, as I said, is not only a disease of the elderly, and we're seeing it more and more in middle age as well. The fact that even the middle age is aging, we are looking certainly at tremendous increases in COPD events. So a clinical diagnosis of COPD should be considered in any patient who has dyspnea, chronic cough and sputum or sputum, and a history of exposure to risk factors for the disease. Spirometry is required. It is the gold standard for making the diagnosis. The goals of COPD assessment are to determine the severity of the disease, just like with asthma. It's not enough to say, yes, indeed, you have COPD. We need to know how severe it is so we can then marry that level of severity to the level of pharmacotherapy, just like with asthma. It's a stepwise approach. So once we know the severity, we can then figure out the correct combination of pharmacotherapy that would be appropriate and helpful for that person. But because a COPD population classically tends to be older than perhaps asthma, because those can often include children, there are often comorbidities just because they're adults, and those are frequently overlooked. So we should look for those comorbidities as well and treat them if they're present. So again, for diagnosis of COPD, we're going to look at symptoms like shortness of breath, chronic sputum production. We're going to look for any exposure to risk factors like tobacco or occupation or pollution, and then we're going to perform spirometry, and that will help us establish a diagnosis. So performed after the administration of an adequate dose of a bronchodilator, and then, as I said before, an FEV1 over FVC ratio of less than 70% confirms the presence of airflow limitation that's consistent with COPD. So once we determine the severity of the disease, then we need to look at a couple things. We need to look at risk of future events, and we need to look at its impact on the patient's health. And that will tell us, that'll help us stage it, and then we can take that stage and determine the best pharmacotherapy for that stage of COPD. So we're going to look at symptoms, we're going to look at spirometry, we're going to look at risk of exacerbations, and look at comorbidities. And that will help us stage the disease now that the diagnosis has been made. So for symptoms, we're looking for the symptoms that we talked about earlier, dyspnea, which is usually progressive, chronic cough, and chronic sputum production. So how do you assess symptoms? Well, I showed you earlier the COPD assessment test. There's also a clinical questionnaire. There's also an mMRC breathlessness scale, which is used quite often as well. And these are different ways to assess the symptoms. I said the CAT and the CQ. But the breathlessness questionnaire is used fairly frequently, and it's the Modified British Medical Research Council, the mMRC questionnaire. And this seems to relate very well to other measures of health status, and this also helps predict future mortality risk. It's a very easy questionnaire. I'll show it to you in just a minute. And it will assign a score, and that's one way that we can help stage the severity of COPD. So this is it. So there are just actually 5 questions that they need to answer, and they would rate themselves on the one box that applies to them. Only one box. They don't grade each one of them. They would apply whichever grade applies to them. So if it's somebody, for example, grade 0, I only get breathless when I'm really exercising strenuously, then they would check that box. If they get short of breath when they're hurrying on level ground or walking up a slight hill, they would check that box. If they tend to walk slower than people the same age on level ground because they're so breathless, or they have to stop for their breath when they're walking at their own pace on level, they would check that box. If they have to stop for breath after walking only about 100 meters or after a couple minutes on level, they would check that box. And if I'm too breathless to leave the house, or I'm even breathless when I'm dressing or undressing, they would check that box. So they're anywhere from a grade 0 to grade 4. So they would assign themselves to the most severe category there. So we've assessed symptoms using the mMRC. Now we're going to assess degree of airflow limitation, and we can easily use spirometry for this. And again, this is all helping us set the staging for severity for COPD. Symptoms, airflow limitation, which is spirometry. And so this is how you would do that. If these are the gold stages. Mild, their FEV1 would be over 80% predicted. Moderate, it would be 50 to 80%. Severe would be 30 to 50%. Very severe would be less than 30% predicted. So again, we're going to stage it based on how severe their lung function is. And the third thing is to assess risk of exacerbation. So we've looked at symptoms using that scale, mMRC scale. We've assessed spirometry here for the degree of airflow limitation. We're going to assess the risk of exacerbations. So if they've had 2 exacerbations or more within the last year, that would indicate high risk. An exacerbation is if they have been hospitalized or they've gone on oral steroids, that would account for an exacerbation. Then finally, here it is. So if they've had 2 or more exacerbations in the last year, or an FEV1 of less than 50%, 1 or more hospitalization would be high risk as well. And we're going to combine these assessments. So remember symptoms using that mMRC scale, airflow limitation based on spirometry, exacerbations, looking at how often they've been hospitalized or gone on oral steroids. This looks complicated, so bear with me for a minute because I'm going to explain it. But this is how COPD severity is staged. So if you look here, on the left is risk. And so if you go from bottom to top, you go from low risk to high risk. And then if you look here from left to right, this is symptoms. So fewer symptoms on the left, more symptoms on the right. And this is based on those scores, on the breathlessness scores. So someone in A down here would have a CAT score, mMRC of 0 to 1, and they would also have a low risk of hospitalizations. They maybe had one exacerbation that did not lead to a hospital admission. So this is low risk, low symptoms. Whereas this side here would be higher risk because they've had more exacerbations and at least one led to a hospitalization, and they have a higher score on the mMRC, so they have more symptoms. And I'll show that to you a couple times here. So we're going to assess symptoms first by the scores. So their mMRC is 0 to 1, they're on the left. If it's 2 or greater, they're on the right. Then we're going to assess risk of exacerbations next. So if they've had one exacerbation that did not lead to hospital admission, they're on the bottom half. If they've had 2 or more, or at least one led to a hospital admission, they'll be on the top half. So this is risk, this is symptoms. Again, we're going to combine both those scores and put them in one of those 4 quadrants, A, B, C, or D. And the reason for that is, it's all going to culminate in this slide, the reason for that is now we know what stage they are. And this is going to tell us the best way to treat them. So for example, someone in A category down here has a lower mMRC score and a lower risk of exacerbations. They have low risk and less symptoms. They'd be at gold stage 1 or 2, and you'll see in a minute, and we'll talk tomorrow extensively about how to treat COPD with the pharmacotherapy. B would be more symptoms, but still lower risk. C would be higher symptoms, less symptoms, but higher risk. I'm getting myself confused. And then D would be high risk and more symptoms. So it just kind of goes up the stage like that. So we also, as I said, need to assess COPD comorbidities. And COPD patients are at increased risk for other comorbidities such as cardiovascular disease, osteoporosis, respiratory infections, anxiety, diabetes, lung cancer, etc. And these can influence mortality and hospitalizations, and they should be looked for routinely. Now, there's also a question about COPD and asthma. How do they differentiate? How do they overlap? COPD tends to present itself more in midlife. You don't typically see children with COPD. And the symptoms are slowly progressive, and there's oftentimes, not always, but oftentimes a long smoking history. Asthma often presents itself early in life, more often in childhood. The symptoms can vary tremendously day to day. They tend to be worse at night or early in the morning. They tend to be affected by allergies. And there tends to be a family history of asthma as well. So there can be differentiation, but there can be overlap. So as therapeutic options, there are certainly appropriate pharmacotherapy that can reduce COPD symptoms and reduce the frequency and severity of exacerbations and improve exercise tolerance and health. None of the existing medications, this is important, none of the existing medications for COPD has been shown conclusively to modify the long-term decline in lung function. So we have nothing yet that can preserve lung function in patients with COPD. The best way to do that is to prevent exacerbations, which takes them down a notch each time they have one, and to quit smoking. That's the best way to preserve lung function, but nothing restores the lung function they've lost. And influenza and pneumococcal vaccines should be offered depending on local guidelines. So we're going to just touch on for a minute in the last few minutes here, and then I'll leave that open for questions. And if that staging confused you, because it is confusing, I will just briefly touch on that tomorrow when I talk about medications. But basically, we're staging based on the symptoms and the risk of exacerbations primarily, and then comorbidities as well as lung function. But the important thing, too, is just remember that there are 4 different stages of COPD, and then there's appropriate pharmacotherapy for each one of those stages, just like as there is with asthma. Although the stages look different and they're assessed differently, it's important to stage it just as you would with hypertension or any other chronic disease. You need to know where to begin and how to treat it appropriately when you're diagnosing it, and then you can adjust therapy as you go. So there are certainly some classes of medications that are used historically in people with COPD that oftentimes look similar to those that are used in asthma, but others are not. Beta agonists, certainly, there are short and long-acting beta agonists. There are anticholinergic medicines, long-acting and short-acting. There are combination medicines that we use, just as we do in asthma, that combine long-acting beta agonists with inhaled corticosteroids, et cetera. There's all different combinations and newer combinations that are coming on board. Inhaled corticosteroids, methylxanthines, which is theophylline. There's systemic corticosteroids, and there, as a phosphodiesterase 4 inhibitors, there are just a whole host of COPD medications, and new ones coming out almost daily. So it's an exciting time for COPD treatment. And some of these are newer, some are older, but many of them are highly effective at least helping someone maintain control of COPD. Again, none of it will restore lung function that's been lost, but if we diagnose early and get them on therapy early, we can sometimes help them prevent future exacerbations, which is really key to preserving lung function. So the medications are really critical strategies in COPD management. So, to be continued, just to whet your appetite, tomorrow morning, 8 a.m., the final webinar in the series will be all about COPD medications. So I invite you to join me tomorrow morning at 8 a.m., and we will go into each of those medications, how they're used, and the risks, the benefits, and any other questions you may have about COPD. And with that, I will conclude the formal presentation part of this, but I would like to leave it open, and I'm happy to answer any questions you may have, either over the phone or in the chat box. Thank you so much for your attention today.
Thank you, Karen. And just so those that are on the webinar, we are unmuting lines right now, so you should be able to ask your questions directly, or if you would prefer, you can also put them in the chat box. So either way, based on your preference.
Being a little bit out of breath. And the bad thing about me, too, is I can hear my heart beating all the time.
Oh, okay. All right, good. All right. Karen, I really appreciated the information, in particular in thinking about the care management perspective and how we identify patients for care management. And you had listed a number of the comorbid conditions that are often associated with COPD.
Yes.
I'm wondering, maybe in reverse, we might think about, because we're not often identifying COPD as a diagnosis, if we're managing those other conditions, would it be good practice then to assess if they have the risk behaviors, the potential of them also having COPD?
Oh, I would say most definitely. If they have any other chronic diseases, if they have heart disease, if they have diabetes, and they're smokers, I would certainly want to at least assess for any of the risk factors, any of the symptoms they may be having. And I think it's just wise practice to do spirometry in someone who has a history of smoking anyway. But yes, I can definitely see going the opposite way.
Great. And then the other question I was wondering about, as far as who can do spirometry, and you had said others on the practice team, must it be a licensed individual, or could you train MA or?
Oh, absolutely. Absolutely. Spirometry can be very easily performed in any kind of primary care setting. It can be done by an MA or by a nurse or any other health professional. They don't have to be licensed as long as they've undergone training and they are at least assessed once a year or more that they are competent to do that. And then the providers may need additional training on how to interpret spirometry. But the maneuver itself, you need to be a good cheerleader, and I've talked about that before, and you need to do it correctly. You just really need to be very motivating and make sure that they're in the right position and they're using their forceful maneuvers appropriately. But yes, anyone can definitely perform spirometry with a patient as long as they have been trained properly. And they're really enthusiastic and able to coach them through the maneuver.
Great. Good information. Any other questions from those that have attended the webinar today? Well, certainly if you think of something overnight, we have the webinar coming up tomorrow morning at 8 a.m. So Karen will be available then. And just as a reminder to get your continued education credit, please go to our website, the www.mixi.org, and go to the COPD overview. You will have the password that you'll need to input to access the information, and that's dyspnea. It's lowercase, so you don't have to put any caps with that. And once you complete the evaluation, you'll be able to download the certificate. And if you have any issues or difficulties accessing it, please do not hesitate to email either Karen Carpenter or Amy Wales at their email addresses listed. So with that, I thank everyone, and we look forward to hearing the next days with the medications and treatments tomorrow morning. So thank you, Karen, and thank you all for signing in today.
Thank you, and we'll talk to you tomorrow morning.
All right.
Thank you.
Okay.
Bye-bye.
Bye-bye.
Right now.